very good evening. My name is Dr. Shakti, and we're going to wrap up with cardiovascular system today by talking about your special circulation system. So, under special circulation, we have your coronary circulation, the cerebral circulation, which are two of the most important things. Apart from that, sometimes fetal circulation can come, and we also have your cutaneous circulation and splanchnic circulation. So these are the topics we'll be covering today. Most important of them is your coronary circulation and your cerebral circulation. Sometimes questions from the fetal circulation can also come. Okay, so we'll start off with your coronary circulation. So coronary circulation. Uh, so if you look at the coronary circulation, the heart by itself cannot utilize, unlike the lower animals, the blood which is there inside the heart. So it needs a specialized system for its circulatory requirements. So for that, we have from the anterior aortic sinus, a right coronary artery which is coming. So this right coronary artery now goes down. It gives off a marginal branch, as you can see over here, and it can go behind and give a posterior descending branch. So most often it is from the right coronary artery that this posterior descending branch can happen. But in some anatomical variations, it can arise from the left coronary artery as well. Apart from that, your left posterior aortic sinus, from there, uh, it gives out the left coronary artery. The left coronary artery will give the anterior descending branch. This is a major left coronary artery branch which is there. And apart from that, we have another branch which is going, which is the circumflex branch, which is going to go. Okay. And apart from that, there can also be marginal branches. So we have the right coronary artery giving rise to your marginal branch and the posterior descending branch. The left coronary artery giving rise to your anterior descending branch and your circumflex branch, which is going behind, and also the marginal branches. So this is again a view from the bottom, and you'll be better able to appreciate your descending branches and circumflex branches actually. Now, apart from that, we have your coronary sinus, which is over here. And you can see here the great cardiac vein. So this is ultimately, after the arterial, the venous drainage is taking it over. Okay. So these terminologies, just keep it over there in your mind so that you'll understand the next thing that I'm going to talk about. So apart from that, what is the area that these right and left coronary arteries supply? The right coronary artery essentially supplies your SA node, the right atrium, the right ventricle, and the posterior part of the interventricular septum. The left coronary artery, on the other hand, supplies your AV node, the left atrium, left ventricle, and septum, its anterior part of the interventricular septum. Okay, so this is one diagram that you have to understand. So basically, there is a coronary artery which is coming. We were talking about it earlier. So all of these coronary arteries are going to end up becoming arterioles. Arterioles open up to capillaries, and from there, venous drainage is happening. So this venous drainage from the right ventricle is anterior cardiac vein. From the left ventricle is your coronary sinus. So as you saw in the diagram earlier, we have the anterior cardiac vein, right cardiac vein, and left ventricle, primarily the coronary sinus. And they eventually open up into your right atrium and goes to the heart chambers. So this is one mode of circulation that is there, major circulation that is there. Apart from that, what happens is there are other system where from your arterioles, it can directly connect to heart chambers through certain sinusoidal vessels, which are arteriosinusoidal vessels. There are ones which connect from the coronary artery directly to the heart chambers, that is arterioluminal vessels. And then we have ones which are from the capillary level, which goes into the heart chamber, which are called Sebaceous veins. Okay, so we have arterial sinusoidal veins, we have arterial luminal vessels, as well as the Hebesian veins. So we have two separate channels of systems which are involved in your coronary circulation. So certain special characteristics of coronary blood flow, it is usually around 5% of the cardiac output, and that will account to around 225 to 250 ml per minute. In terms of per 100 gram of substance, it is around 60 to 80 ml. Now, if you look at the arterial saturation, it is around 19 ml percentage, venous will be 14 ml per. This is generally in the rest of the body. And the arteriovenous difference comes to around 5 ml percentage. You learn about this in respiratory system. This is how it predominantly is in most parts of the body. But when you take a look at your coronary circulation, at the level of venous level, if you look at the percentage saturation, it is around 7 ml percentage. That means the oxygen extraction is much more higher over here. Okay, so the AV difference is coming to around 12 milliliter percent. So the extraction ratio is much higher. And usually at rest around 70 to 80 percentage of oxygen is extracted from each unit of blood. Now, when you talk about the oxygen consumption, so usually the basal oxygen consumption comes to around 2 ml per 100 gram per minute. And once it goes to a beating heart, uh, it goes to around 8 to 9 ml per 100 gram per minute. The thing is, it should have at least 1.3 milliliter per 100 gram per minute to stay alive. This is important because if there's some sort of blockage and the flow becomes less than this level, then that becomes problematic. So this is one often asked question. It can come as a short note. Okay, what are the factors or affecting or what are the determinants of coronary blood flow? You can talk about it under four headings. One, what are the pressure differences which are there from the point of the ventricle and the aorta or the pulmonary vasculation? So that pressure difference. The effect of the systolic compression on the coronary circulation. Three, we can talk about the chemical factors which are involved, and then we can talk about the neural control. Okay, so these are the four headings under which we're going to be talking about this term. So first, we'll talk about the pressure difference. So here you can see your aorta. Okay, so usually 120 by 80 is normal BP that we're talking about. And of course, in the left ventricle, it has to be higher in order for a flow to happen. So we just put a value of, say, 121. So whatever it is, ultimately what is going to happen, uh, if you look at the pressure difference between the aorta and the ventricle, you see that in the level of the left ventricle, less as a result of this. Okay, so ultimately what is going to happen from your aorta, that is where your coronary circulation is gonna come to your heart. Okay. So in systole, what do you see? Left ventricle has less pressure than, sorry, your aorta has less pressure than your left ventricle. So will there be flow, in this direction? There will not be any flow in this direction. Okay. But on the other hand, if you look at the right ventricle, uh, pressure is much lesser. It is around 25. And you see that because of this, from a higher pressure of 120, which is there, from the aorta, it can pump to your ventricle. So there is a pressure difference gradient of around 95 for this. Okay. But on the other hand, if you look at the diastole, during diastole, the inside the ventricles, it is near to zero. Okay. And the minimum pressure which is there outside is your diastolic pressure, which is 80. So obviously that minimum difference is gonna be there always. So diastole is never an issue. Flow is gonna happen. Okay. So the only thing is during systole, the pressure difference between the aorta and the left ventricle, which is there, that will not allow a flow for the coronary circulation. Because flow in the pressure inside the left ventricle is higher than the pressure which is given from the aorta and going into the heart for coronary circulation. So in systole, will there be a flow? There will not be a flow. The flow actually reduces. Okay. On the other hand, diastole, it comes up. But one thing you have to notice is not only does it comes up, it goes beyond what it was there initially and goes beyond that. Okay. So this effect is not only because of the pressure difference, but also the compression. This is the second heading that we are talking about. So again, during systole, your cardiac muscle is constricted. And the muscles are constricted and the vessels are passing through them. Okay, that is how the nature of the blood vessels are. Okay, how they are flowing is actually you have your blood vessels, which now coronary circulation goes through inside, and it goes through like this through the layers inside. So this is the area where the muscles are there. So if the muscle is constricting, there is no passage of blood inside. So just by the systolic compression by itself, it will not allow flow to go through that tank. But instead, what happens during diastole? There is going to be flow. But during that whole time, there is accumulation of metabolites, because of which there will be higher flow in the diastole. So as you can see over here, uh, this is the period during your systole. This is the aortic pressure. So during this increase in the aortic pressure, you do not see a corresponding increase in your um, coronary blood flow in the left side. Okay. On the other hand, if you see here, the right from compared to this level, the right has an increase. Okay, so initially this drop and it did not rise enough. Here, right had an increase. On the other hand, the left side, eventually during diastole, it becomes much more higher. And the right coronary does not become that high during diastole. Still flow is there, but it will not become that high because the metabolite accumulation did not happen much over. Okay, so this was the pressure gradient which was existing at the level of your uh, right-sided coronary artery circulation. Okay, so again, same thing only, just skipping it. So we talked about your pressure, we talked about your uh, compression. Now we're going to talk about the vasodilator metabolites that I was talking about, the chemical involvement over here. So what happens is, during systole, when not enough blood is coming in, there is decrease in the PO2. If increased oxygen means ATP gets utilized, ultimately more of adenosine is there. Okay, more of adenosine along with all of these factors. For example, increased PCO2, increased H plus, increased potassium, increased lactate, and other factors like prostaglandin, nitric oxide, all contribute towards a vasodilator state, resulting in increased flow during your diastole especially, or in any, not only here, in any situation. For example, there's some sort of asphyxia, hypoxia is there, okay, or some sort of intracoronary cyanide injection. Whatever you do, this will result in local vasodilator metabolites trying to increase the blood flow to the area during this time. Okay, and this can increase up to 200 to 300% increase in coronary blood flow. So this is the chemical part. Now, if we talk about the neural part, most important thing is understanding how a direct effect is there and how an indirect effect is there. And ultimately, the indirect effect predominates. So what happens is directly by the effect of your neural interface, norepinephrine is there. Ultimately, what does it do to any vessel? Through alpha 1, it results in constriction. Okay. So through alpha 1, it results in constriction. Beta 2 is only present in skeletal muscles, for example, in certain areas or not. So not something we're going to be talking about over here. So alpha 1 related vasoconstriction. So ultimately, neural control of this would ideally result in decrease in the blood flow. Coronary circulation should decrease. But indirectly, there's another effect. The same catecholamines, what do? they act on the beta 1 receptors and result in increase in the force of contraction, increase in the cardiac output. Increased cardiac output means increased coronary blood flow. Okay, that is one thing. Second thing, the alpha 1 effect on the peripheral circulation will shift all the blood towards major organs like your brain, the heart. So because of these two indirect effects, although the direct effect of your neural control is, to increase vasoconstriction and result in decreased flow, but because it indirectly affects the cardiac output and circulation in a way, they eventually try to increase the blood flow through this indirect measure. So that is more important over here. Okay. So once we talked about your coronary circulation, we'll go to your cerebral circulation. When you talk about cerebral circulation, we have the internal carotid artery. From there, from the anterior cerebral artery, we have the middle cerebral artery. Okay. These two come from the internal carotid artery. And from the vertebral artery, the basal artery is formed, posterior cerebral arteries. And between them, you link by communicating artery, the anterior, the posterior communicating arteries, you have the circle of Willis, which is okay. So this is your blood supply. So this blood supply, the anterior cerebral artery supplies predominantly the anterior part and the medial part. As you cut it and go inside the medial part of it. Okay, the middle cerebral artery is mainly for the lateral parts. Okay, and the posterior part, okay, as you can see down and over here is given by the posterior cerebral artery. So posterior as well as this inferior part that you see over here. Okay, so peculiarities about your cerebral circulation. The normal blood flow, you can see in ml per minute is much higher compared to your coronary circulation, which is around 225 to 250. Here it is 750 to 900 ml per minute. But if you look at the per 100 gram per minute, it is less than how much, or almost similar to how much you get in your coronary circulation, that is 50 to 65 ml per 100 gram per minute. Okay, now another thing is that the brain is only 2% of the body weight, but receives 15% of the cardiac output, as you can see over here. Okay, coronary circulation, you get only 5% of the cardiac output. This receives around 15% of the cardiac output. Now, out of the flow that is coming, the gray matter seems to receive a major chunk of it. Around 60% of the chunk of it is received by the gray matter, and white matter receives the remaining 40%. Now, even here, we have a critical level. This, if it falls less than 18 ml per 100 gram per minute, that can result in damage. And when there is a total cessation of blood flow, within 5 to 10 seconds, there can be unconsciousness. Okay, and even the consumption of oxygen, usually it's around 3.5 ml oxygen per 100 gram per minute. Okay, and the gray matter uses it more compared to white matter. It makes no sense because all the neuronal bodies are in the gray matter. White matter is only for conduction. Now, there is a concept of auto-regulation of cerebral blood flow, and usually there's a range between 65 to 140 millimeter mercury. So it can either be because of some myogenic cause. So whenever there's an increase in the pressure, there is uh, through a calcium-mediated mechanism, it can result in a constriction. This happens especially in smaller vessels. And metabolic, like hypoxia, hypercapnia, acidosis, all of that again can result in local vasodilator metabolites and can result in vasodilation. Neural, again, sympathetic system can result in vasoconstriction. But this is one thing I want you to take a look at. So this is generally something we do not otherwise see in your systemic circulation, but there is a cholinergic vasodilation which actually happens in the cerebral circulation. So we do not really have receptors per se in the rest of the body, but in your brain, a cholinergic mediated vasodilation does seem to happen. Okay. So what are the factors that affect the cerebral blood flow? These are the various factors that affect the cerebral blood flow. Okay, so we can talk about the first thing, that is intracranial pressure. So you can talk about it with respect to Monroe-Kelly doctrine. So what Monroe-Kelly doctrine says is there is a closed space in the head, okay, where we have blood, which is coming in circulation. Okay, we have a particular amount of CSF and the volume of the brain. So this entire thing should be, the same. All three of them should be ultimately the same amount. Okay, the volume of this should be totally the same. So even if, for example, increase in the CSF volume is there, how will that happen? For example, increase intracranial pressure. Intracranial pressure is increasing because of some reason. Then what will happen? The It will squeeze the brain and decrease the volume. And it might even reduce the blood. So that much of increase in CSF was there. Or for example, there is a tumor which is growing. As a result of this, the volume of the brain increases. Okay, so anyway, when there is any changes in the volume of the brain, volume of CSF fluid, that can in turn reduce the volume of blood. Okay, so one of the things we're talking about is intracranial pressure. So that is one thing. Second thing is the mean arterial pressure and the mean venous pressure. So why is it important? You look at the intracranial pressure, mean arterial blood pressure, mean venous blood pressure. So this determines how much blood is coming up, and this is determining how much blood is going out. So that ultimately determines how much blood is staying here in the system. Okay, so when a positive G is given, okay, so you're on a lift and you're going up, what will happen? The blood from here will get drained down, okay, and it will happen here also. As a result of that, eventually it will result in a reduction in the brain space. Okay, so that is one thing. So when the intracranial pressure decreases, that will result in less compression. Okay, so one thing is in a positive G scenario, the BP, which is here, reduced. Okay, but this blood is what is giving your intracranial pressure as well. So that will eventually result in less compression of that by reducing the intracranial pressure. And thus it will try to stay patent inside. Okay, on the other hand, a negative G is given. A lot of blood is going up and it is hindering how much is going down also out of it. So ultimately, it will result in increase in the intracranial pressure. So you do not want so much BP over here. So what will happen? This increase in the intracranial pressure by itself will result in a compression so that the flow here will not be increased. Instead, it will be compressed and the flow will be affected. Okay, so that is the role of the mean arterial pressure. Then, of course, the viscosity of blood. As the viscosity of blood increases, the flow decreases, like in any other place. Then, local vasodilators, constrictors, and all that. For example, increased PCO2 is there. Okay, that will give ultimately H plus or some lactic acid, pyruvic acid, whatever, will again give H plus. Or the simple fact that oxygen is less. They all result in vasodilation. Okay, so that is it about your cerebral circulation. Now we'll go to your cutaneous circulation. When you talk about your cutaneous circulation, we have the epidermis over here. We have the dermis over here. Now, this is how the dermal vasculature is going to be. On the other hand, you'll see that in the epidermis, you do not actually see any sort of vasculature. Okay, we have a superficial plexus, we have a deep plexus. So we have the connective tissue area where a deep plexus is there. Above that, we have a superficial plexus which is coming out. Epidermis does not have any blood circulation. Okay. Now, this is mostly involved in temperature regulation. How is it involved in temperature regulation? This is the epidermis, we have the artery, we have the venous system which is coming. Okay, so either it can vasodilate or vasoconstrict based on the requirement. For example, if there is vasoconstriction, what will happen? It will limit how much blood is flowing through this. Okay, or if there is vasodilation, there is more blood flowing, which means more blood is there means more heat can be dissipated. Or if, for example, we need to conserve your body temperature, you're in a cold place, you do not want a lot of heat loss. So then you vasoconstrict. Okay, this is under autonomic control to a degree. So one of the ways by which temperature regulation is your direct conduction, which is taking place. Okay, conduction directly can take place, or a convection current can happen, or directly from here, a radiation can happen. Or we have the sweat glands, which can result in sweating and eventually evaporation and heat loss. Okay, so one thing I didn't show in the previous diagram is this particular structure that we see here, which is called the glomus body. Okay, we have a structure called the glomus body, which is particularly present in a particular type of skin, which is called apical skin. This apical skin is in certain areas, like for example, your nose, lips, ear, hand, feet. It's not everywhere, it's only there in certain specific areas, like the nose, lips, ear, hand, feet, and all. Okay, so if you notice, in a cold place, these are the parts that you will feel very cold. So these are what are mostly involved in temperature regulation, the apical parts of the skin. So what is different over here? The difference is with regard to a particular arteriovenous anastomosis where a glomus body is in. So this, what does it do? It becomes a low resistant pathway. So it will bypass this capillary bed. This capillary bed which is there, okay, this capillary bed which is there, it will bypass that capillary bed. Instead, it will go through this. Okay, so based on the level of vasoconstriction, vasodilation, it can in turn help conserve heat. Okay, or it can result in heat loss. So again, that is the importance of your apical skin and the glomus body and how it acts. So this is again an example of a counter current. Okay, counter current system. Okay. Now, apart from that, your non-apical skin is mainly, having a nutritive function, not that involved in your, temperature regulation. But over there also, to a degree, your sympathetic effect through the norepinephrine can result in vasoconstriction, or through acetylcholine indirectly can result in vasodilation, or directly. There are no receptors for your muscarinic receptors you don't see over here, but instead what happens is it can, through bradykinin, can, indirectly result in a vasodilation. Okay, so these are some peculiarities that you can talk about when you talk about your skin and its cutaneous circulation. Then we have the splanchnic circulation. So splanchnic circulation, if you take a look at it from your aorta, abdominal aorta, you have the celiac artery which is coming. Okay, you have the hepatic artery, and eventually it becomes the superior and the inferior mesenteric artery. So this, you can see here certain areas in the intestine itself are superior and certain areas are inferior mesenteric artery. So ultimately, this inferior mesenteric artery, whatever is coming, or superior mesenteric artery, eventually they will all come up and go through the portal vein. Okay, so there is a portal vein. Apart from the hepatic artery which is going here, through a separate portal vein, they will go, and then eventually they will form the hepatic vein and taken to the inferior vena cava. Okay, so again, you can see here the structure of your arteries applied to the intestine, and how superior mesenteric as well as inferior mesenteric arteries are involved. But ultimately, when they go for the different layers, they pass through each of these separate layers and go deeper and deeper, and they reach the villus, where they eventually form a countercurrent system. This is very important. A countercurrent system is also formed at this level. What does a countercurrent system do? It prevents loss by bypassing like this because it is very close to each other. So you do not want a loss of substances much over here. You just want substances to be taken down. Okay. So this is one form of countercurrent arrangement that you see over here with a central lacteal system which is there. So fat absorption and all partly is happening with your lacteal system. Apart from that, your artery and vein, and that is helping you for your absorption from the intestine. Now, everything finally, as we were talking about, goes to your portal vein, and from the portal vein, it goes through the hepatic sinuses, hepatic vein, and then comes up the vena cava. Okay, so the portal vein is formed from your splenic vein on one side and your intestinal vein, which is coming on the other side. So one thing we talked about is countercurrent system. What are the factors that affect it? One, post-meal, usually blood flow increases in the splanchnic circulation. Okay, almost, 8 times increase in the blood flow is seen post-meal. We have neural control, which can be either, local enteric system or directly from the cephalic through the vagovagal reflex, something like that. Okay. Or hormonal involvement, where GI hormones like cholecystokinin, neurotensin, all can increase. Okay. Even the nature of the luminal contents like bile acid, partially digested fat can be detected by chemoreceptors, which can result in hyperemia in that area. Okay, so these are all different factors which affect the splanchnic circulation specifically. Now, finally, we'll come to fetal circulation. So again, this usually is asked as a question, fetal circulation. So again, as I was telling you, coronary circulation, cerebral circulation, then fetal circulation is very important. Fetal circulation can come as a separate short note. Okay, so the first thing is with regard to the uterine flow. So usually uh, after conception, you will generally see that the uterine flow is increasing. Uterine flow is increasing as the fetal weight keeps increasing. Now, corresponding to this, you will also notice that there is decrease in the oxygen saturation in the arteriovenous difference. When you check, the oxygen saturation keeps falling, which means the oxygen extraction is also increasing. Okay, so although a 20 times increase in the uterine blood flow is there during this period, according to that, the fetal weight is also increasing. So that does not, meet adequate requirements. So you have to, in turn, result in more oxygen extraction also. This is at the level of your uterine circulation that we're talking about, where the placenta is there. Okay. Now, if you look at the placenta, it will be a structure like this. We have the spiral arterioles which are there. Okay. And your intervillous space, which is here. Okay. And we have the villus structure. And from there, you see the umbilical vein and the umbilical artery. So this is one thing that you have to understand. Umbilical vein. So you talk about heart. Okay. Anything which is going to the heart is a vein. Anything which is coming out of the heart is an artery. Okay. So this umbilical vein eventually is going to the heart of the child. And from the heart of the child, your umbilical artery is happening. So in turn, what is happening? This is acting like a lung instead of your action lung of the child. Okay, so that is why your umbilical vein is carrying oxygenated blood. Okay, and your umbilical arteries is taking the deoxygenated blood for oxygenation into the placenta. But just know that placenta is a little thick, not like the alveoli, and because of which the saturation, never gets to your proper 95, 97 percentage that you get otherwise. It goes to, usually around 80 percentage. Okay, so again, you can see over here. So by the end of this, what is going to happen? So what is coming from the placenta, that forms your umbilical vein. Now, this umbilical vein, what it does is it goes like this through your liver. Okay, it bypasses the circulation, the portal circulation. Instead, it directly goes to the inferior vena cava. So this is through your ductus venosus. Major part goes like this. Okay, so that is usually coming to say around 80% saturation, which was coming as I was telling you earlier. That 80% saturation is coming here. Now, whatever is being picked up from the body through this portal circulation, that is usually as less as 26%. Okay, finally, when they two mix around this level, it comes to around 67%. Okay, so the saturation will help it and comes to around 67%. Now, this which is coming from the inferior vena cava, what happens is it goes up, reaches the right atrium, and immediately goes in this direction. So what again happens? It goes from here, okay? It goes from here through the foramen ovale. There's a small hole over there. Through the foramen ovale, it goes to the opposite side. So it does not go from right atrium to right ventricle. Instead, it directly goes from right atrium to left atrium like this, through the foramen ovale. Okay, and goes to the other side, where it'll go to the left ventricle, which will eject it out through the aorta. Okay, so this is predominantly going where? To your head and neck region. Okay, majorly the head and neck region, this is going to. Okay, so good oxygenated blood that we just got from here will majorly go like this and reach the head and neck region. Now, instead, what will happen? The rest of the blood. Okay, so from the head and neck region, whatever is being drained is coming through superior vena cava. Okay, what will that do? That will go like this. Okay, so what will happen? This will go like this, go down instead of going through foramen ovale. It'll go down into the right ventricle and it'll go through the pulmonary vessel. And as it is going through the pulmonary vessel, it tries to go to the lung. But the pressure and the resistance over there is so high because it's not inflated. It will not pass through that. Instead, it will reroute itself and come through the small opening, a connection over here, which is called ductus arteriosus, which directly connects it to the aorta instead. Okay, so instead, what will happen? This will now go. So this is deoxygenated blood. Okay, so this deoxygenated blood will now go down from this level. So what did we see earlier? Whatever oxygenated blood which was coming, which went through the foramen ovale, comes down to the left ventricle, goes up and goes to the head and neck region. The rest of the aorta is where the ductus arteriosus will bring deoxygenated blood from the top and come down. So the lower part, the trunk and the lower part of the body will actually receive more deoxygenated blood. And with that, you see that, this is coming to around 60% saturation. And it will eventually be taken by your umbilical arteries, where it will now go back to your placenta. Okay. So again, you can see here a simplified version of what we are talking about. We have the placenta over here. Okay. Now, whatever is coming from the placenta will eventually reach the right atrium. So this I'm drawing it up for you to make it easier. From the placenta, it will come all the way to the right atrium. From the right atrium, it will directly go to the left atrium, to the left ventricle, and go to the body. Which part of the body? The upper head and the neck region. Okay. On the other hand, whatever is coming from the superior vena cava, that will go to here. It'll go here. Okay. It cannot go here. Instead, it'll go through this and it'll go to which part of the body? The lower part of the body. And this will now be taken back. Where? Into the placenta. Okay, so this is not a complete picture. That's why I'm just drawing all of this to help you understand. So in this whole thing, this area is not in use right now. Okay, so one of the things that happens with birth, we do not exactly understand what stimulates the first breath in a newborn baby, but postulated theories involve either light, sound, cold air, tactile stimuli, or a combination of these. That will result in first gasp and will result in increased oxygen. Now, oxygen has differential effect in the pulmonary circulation and systemic circulation. Oxygen is vasodilatory in one region. Okay. And it results in vasoconstriction in most of the other region. Okay. So in your systemic circulation, vasoconstriction is what you see because of oxygen. In your pulmonary circulation, oxygen will result in vasodilation. Okay, so because of that, the resistance which was earlier there in the pulmonary circulation will reduce. Okay, that is one thing. Second thing is the oxygen will also result in vasoconstriction of your umbilical artery, ductus arteriosus vena. So now, as this is happening, what will eventually happen? The uh, circulation now changes a bit, where the pulmonary resistance, which was earlier there, this resistance is no longer there. So instead, what will happen? The blood, once it starts going through the lungs, now it will start coming like this. Okay, so what will happen? Left atrium is now receiving a lot of extra blood. Earlier, the blood which is coming from the foramen vein is there. On top of that, whatever is there in the lung. So left atrium is getting a lot of blood and higher pressure there will make it go flow in the opposite direction, resulting closure of foramen ovale. Okay, once the foramen ovale is closed, then it'll start going instead in this route. And now because of this, the pressure here in the left ventricle will be much higher, ejection pressure. So the flow will no longer be from the right ventricle through the ductus arteriosus. Instead, it will start reversing. Okay, and with time, usually ductus arteriosus, as we were talking here, because of oxygen, will start constricting. Functionally, immediately its function reduces, but it'll take another 24 to 48 hours for more proper closure of it. Okay, then at the end of this, your adult type of circulation will develop where nothing else is there in between. What will happen? Your body will receive right atrium, right ventricle goes to the lung, left atrium, left ventricle goes to the body. That same thing keeps happening. Okay, so that is with regard to your fetal circulation. So talking about Auricle, Auricle has foundational classes which have been pre-recorded and you can watch it at your own disposal and time as per your requirements. Live sessions are for you to interact with the examiners, faculty which is there, ask your doubts, okay, and for you to get a feeling of being in a live class. The Express Exam module helps you complete the syllabus in less than 20 hours. Okay. The thing is, all these pre-recorded sessions are made shorter for you to prepare for the exam, keeping in mind the examination and the questions. There's also one-to-one doubt clearing sessions and hard copy notes are there. So this will help you give, colorful diagrams, notes are there, MCQs are there, fun facts are there. Okay. Apart from that, there is also different types of question banks with different difficulties. And of course, even practical sessions have been pre-recorded and provided. These are the various subscription plans which are currently available. And you can use my code Dr. Shakthinag 20 for discount on subscription. So thank you for watching. If you want to contact Team Auricle, you can go to any of these social media handles of this. Thank you for watching. See you again next time.